All right, let's dive into something pretty fascinating and honestly super important, the world of immune hypersensitivity. Have you ever wondered what's actually going on inside your body during an allergic reaction? We're talking everything from a simple case of hay fever all the way up to life-threatening anaphylaxis. Well, if you have, you are in exactly the right place. We are going to break down all the core mechanisms in a way that's not just clear, but really clinically relevant.
So here's our roadmap for today. We're going to kick things off with the four main types of hypersensitivity. Then we'll look at the timeline of a reaction, how it plays out over time. From there, we'll get into the real nitty-gritty of the pathophysiology, see how all this applies in the super high-stakes world of surgery. Then we'll zoom in on a key player, histamine, and finally, we'll tie it all together by looking at some major autoimmune diseases. Sound good? Let's get to it.
Okay, let's jump right in. To really get a handle on what's going on with these reactions, we need a solid framework. The gold standard here is what's called the Gell and Coombs classification, which does a fantastic job of sorting these seemingly chaotic reactions into four distinct types. And it's all based on what the immune system is actually doing. We'll kick things off with type 1.
So, type I. This is the one we're all pretty familiar with. It's that classic immediate allergic reaction. It's all about an antibody called IgE. So here's the play-by-play. The very first time you're exposed to an allergen, your body creates these very specific IgE antibodies. But they don't just float around. No, they attach themselves to mast cells, which are kind of like little grenades just packed with inflammatory chemicals. The next time that allergen shows up, it latches onto these IgE antibodies, and that's the trigger. The mast cells instantly degranulate. They basically explode and release this flood of mediators like histamine. This chemical flood is what causes all those immediate effects. Your blood vessels dilate, they become leaky, and your airways constrict.
So what does this actually look like in the real world? Well, we're talking about things like allergic rhinitis, hay fever, urticaria, which is hives, asthma, and of course, the most feared outcome, anaphylaxis. Now, in a hospital setting, especially during surgery, this is a code red situation. Anaphylaxis during the start of anesthesia, that induction phase, is an absolute nightmare scenario, mainly because the patient can't tell you what's wrong. And to make it even trickier, the symptoms can look totally different from one person to the next. Okay, next up is type 2, the antibody-mediated cytotoxic reaction. This time, the culprits are two different antibodies, IgG and IgM. And instead of just triggering a chemical release, these antibodies directly target and attack our own cells. It's kind of like a case of mistaken identity. They do this in three main ways. First, they can activate something called the complement system, which is basically calling in an airstrike to blow up the cell. Second, they can tag the cell for destruction, a process called opsonization. It's like painting a giant target on its back so other immune cells know to come and eat it. Or third, they can just directly mess with the cell's function, causing it to die.
And the results of this kind of cellular attack are pretty diverse. This is the exact mechanism behind a bad blood transfusion reaction, where the body just starts destroying the incompatible red blood cells. It's also the driver behind conditions like autoimmune hemolytic anemia and hemolytic disease of the newborn. We see it in Goodpasture syndrome, which attacks the kidneys and lungs, and in myasthenia gravis, where these antibodies block signals between nerves and muscles. And even some drugs, like certain antibiotics, can accidentally trigger this type of self-destruction. Now let's move on to type 3, which is the immune complex-mediated reaction. This one's a bit different. See, the antibodies aren't attacking cells directly here. Instead, they bind to antigens that are just floating around in the blood, and they form these little clumps called immune complexes. Think of them like sludge building up in your pipes. Normally, your body can clear these out, but sometimes they get too big, or there are too many, and they get stuck in tiny blood vessels, especially in places like the joints, skin, and kidneys. Once they're lodged there, they trigger a massive inflammatory response, causing all kinds of tissue damage simply because they're in the wrong place at the wrong time. Classic examples of this? Well, there's systemic lupus erythematosus, or SLE, serum sickness, and a type of kidney disease that can happen after a strep throat infection called post-streptococcal glomerulonephritis. And this really highlights the key distinguishing feature. The inflammation isn't targeted at one specific cell type. It's just widespread, collateral damage caused by these clumps getting stuck in the microvasculature.
And finally, we have type 4. Now this one is in a whole league of its own. The key thing to remember here is no antibodies involved, not a single one. This is a T-cell mediated response, and it's delayed. Unlike the instant reaction you see in type 1, this one takes a day, maybe even 2 or 3, to really show up. So here's what happens. On a second exposure to an antigen, specialized T cells recognize it and sound the alarm by releasing chemicals called cytokines. These cytokines then call in the heavy-duty cleanup crew, the macrophages, which then cause all the inflammation and tissue damage. It's a much slower, grinding, cellular assault.
We see this all the time. It's the itchy rash you get from poison ivy. That's contact dermatitis. It's the little bump you get from a TB skin test. It's even involved in the body's attempt to wall off tuberculosis bacteria by forming granulomas. And crucially, it's the main reason why organ transplants get rejected. So the number one takeaway for type 4, it's all about the T lymphocytes.
Okay, so we've got the 4 types down. Now, let's zoom back in on type I for a minute and really look at its timeline. Because a big allergic reaction isn't just a single event that happens and is over. No, it actually happens in 2 pretty distinct waves, an early phase and a late phase.
So on one hand, you've got the early phase. This is the immediate hit, kicking in within just a few minutes, maybe up to 30. It's completely driven by those preloaded mast cells releasing their chemical arsenal, and that causes all the acute symptoms we think of. But then, hours later, usually between 4 and 24 hours, the late phase begins to develop. Now, this isn't about preformed chemicals anymore. This is a second wave of attack where new inflammatory cells, like eosinophils and Th2 cells, are recruited to the site, and they cause a more persistent, nagging inflammation and tissue swelling.
So just picture this timeline. In the first 5 to 30 minutes, bam, the early phase reaction hits hard with those acute symptoms, bronchoconstriction, vasodilation. But the reaction isn't over, not by a long shot. Around the 4-hour mark, the late phase starts to ramp up as those new inflammatory cells arrive on the scene. And by about the 24-hour mark, this second wave is at its peak, causing that persistent inflammation, edema, and symptoms that can really drag on.
So how does the body even learn to have an allergic reaction in the first place? It's not something we're born with. Let's trace the steps, from the very first time you encounter an allergen all the way to that full-blown inflammatory cascade.
It all starts with step 1, sensitization. The very first time you meet an allergen, your immune system's CD4 plus T cells, your helper T cells, get activated, and they differentiate or specialize into a type called Th2 cells. That leads to step 2, IgE production. These Th2 cells then act like little generals, ordering your B cells to start churning out huge amounts of allergen-specific IgE antibodies. In step 3, priming, all those IgE antibodies go and stick to the surface of your mast cells and basophils, basically loading them up and preparing them for a future attack. Then we get to step 4, re-exposure and degranulation. The next time that same allergen enters your body, it finds these prime mast cells and links up the IgE on their surface. This cross-linking is the trigger that causes the mast cells to degranulate, releasing that flood of chemicals and kicking off the early phase. And finally, you get step 5, the late phase infiltration, where that second wave of inflammatory cells, eosinophils, basophils, and so on, are recruited to the site, keeping that inflammation going.
Now, let's take all this knowledge and apply it where the stakes are arguably the highest, in the operating room. For anyone in anesthesia, this isn't just some abstract theory. Understanding these reactions is absolutely crucial for patient safety.
So this is the million-dollar question, right? What does this actually look like when the patient is asleep under general anesthesia? They can't tell you they feel itchy or that they can't breathe. The signs can be incredibly subtle and really easy to miss if you're not vigilant.
A perioperative reaction can hit multiple systems all at once. You might see cutaneous signs, on the skin, like flushing, hives, or angioedema. You could see the respiratory system react with bronchospasm and wheezing that makes it suddenly really difficult to ventilate the patient. Or you could see the cardiovascular system just crash with a sudden, profound drop in blood pressure, hypotension, a racing heart, or even full-on cardiovascular collapse. But here's the most important note, the thing you have to remember. Sometimes you see no skin signs at all. The very first indication that your patient is having a massive anaphylactic reaction might be nothing more than a sudden, unexplained drop in blood pressure or a new difficulty with ventilation. That's it.
So given all the things that happen during a surgery, is there a specific moment when this is most likely to occur? Yes, absolutely. The most dangerous time by far is during the induction phase, those first few minutes of anesthesia. And it makes sense if you think about it. This is when the patient gets a rapid-fire cocktail of powerful drugs. We're talking muscle relaxants, antibiotics, anesthetics, all at once. It's the perfect storm for triggering a reaction, and it is the most critical window to be on high alert. Okay, we've mentioned the word histamine a whole lot, so let's put this one molecule under the microscope. It is the key player in a type 1 reaction, and honestly, if you understand what histamine does, you understand why allergies feel the way they do.
So when those mast cells and basophils degranulate, they release this massive wave of histamine. This histamine then goes and binds to what are called H1 receptors all over the body. When it hits blood vessels, they vasodilate and get leaky, which causes redness and swelling. When it hits the lungs, the bronchioles constrict. It also triggers mucus secretion, itching, and sneezing. I mean, this single molecule is the direct cause of almost all the classic allergy symptoms we know, from a simple runny nose and congestion all the way to life-threatening bronchospasm.
All right, to wrap things up, let's connect these concepts to a couple of major autoimmune diseases. This will really help us see how these hypersensitivity mechanisms can lead to chronic, long-term illness.
First up, let's look at lupus, or SLE. As you can see right here in the table, the pathophysiology is pure type 3 hypersensitivity. It's that immune complex-mediated disease. Those little clumps we talked about get lodged in small blood vessels pretty much all over the body, and this is why the clinical features are so widespread. The complexes cause inflammation in the skin, leading to that classic malar or butterfly rash. They cause it in the joints, leading to pain, and critically, they cause it in the kidneys, which can lead to serious renal disease. Diagnosis is pretty complex, but it often starts with looking for anti-nuclear antibodies or a positive ANA test in the blood, along with a whole host of other criteria.
And next, we have rheumatoid arthritis, or RA. This is a chronic autoimmune attack specifically on the lining of the joints, which is called the synovium. It involves a mix of mechanisms, but autoantibodies like rheumatoid factor, RF, and anti-CCP are key drivers, along with cytokines. This constant inflammation is what causes the classic symptoms: morning stiffness, symmetrical swelling in the joints, especially in the hands and wrists, fatigue, and over time, this unrelenting inflammation can actually destroy cartilage and bone, leading to some pretty severe joint deformities. Diagnosis here involves putting together the clinical picture with blood tests for those specific antibodies and imaging of the affected joints.
So, we'll leave you with a final, critical question to think about. We know for a fact that type 1 reactions are explosive, and that the single most dangerous moment is right at the start of anesthesia. So the real challenge is, how can we optimize our clinical protocols to better anticipate and manage anaphylaxis during that incredibly brief, high-stakes window? There's no easy answer, of course, but it all starts with vigilance, preparation, and a solid grasp of the very mechanisms we've explored today.